Thank you. I'm so excited today to introduce Dr. Peter Singer. He's played a big role in my life, in my innovation journey. So I just wanted, I asked Kaberi, I really want to introduce him. We are so happy to have him. So over to, I just don't know where to start. Dr. Singer, you have had such a good, such an illustrious career. So today, he speaks to us as Special Advisor to the Director General of the World Health Organization. He's the Assistant Director General of the World Health Organization. He supports the Director General to transform WHO into an organization sharply focused on impact at the country level. He co-chairs the transition team, and he's the chief architect of WHO strategy and its $3 billion target. I hope you can talk a little bit to us about that. And amongst the very many roles that he has to do, the thing that caught my attention was setting up multilateral partnerships through the SDG Global Action Plan. During the pandemic, he has been a passionate advocate for vaccine equity, and which is what he's going to talk to us today. But before joining WHO, Dr. Singer co-founded two innovative results-driven social impact organizations, and one of which was Grand Challenges Canada. As the CEO of Grand Challenges Canada, he raised about $450 million to support 1,000 innovation in more than 90 countries. And that impacted about 35 million lives by 2030. He was also the Sun Life Financial Chair and Director of University of Toronto's Joint Center for Bioethics. In 2007, Dr. Singer received Michael Smith Prize as Canada's Health Researcher of the Year in Population Health Sciences. In 2011, he was appointed Officer of the Order of Canada. He's a Fellow of the Royal Society. He is he's been the Foreign Secretary of the Canadian Academy of Health Sciences. He's a member of the US National Academy of Sciences, of Medicine, and the Academy of Sciences for the Developing World. He's also published 300 articles, mentored hundreds of students. His background is in internal medicine, medical bioethics, public health, and management. We are so happy to host you, Dr. Singer, and so all ears, about the topic that you really so passionately care about. Thank you so much for being with us today.
Well, Nikki, thank you so much for that very, very generous and kind introduction. And of course, it's wonderful to see many old friends from McGill here. And I am going to leave quite a bit of time for discussion, because that'll be the part where I can hear from you, your ideas, and just to acknowledge the leadership of many people on the call on the topic we'll talk about, which is vaccine equity. I know that for example, Professor Kaberi Dasgupta and 228 of you have sent a letter on this topic. And of course, Madhu is always advocating. And so just to acknowledge that I think we're fellow travelers here. I'll just take maybe 20 minutes to sketch some of the lessons of the pandemic, which I think has to start with some of the failures of the pandemic, some of the solutions, and I'll focus on vaccine equity, but I'll go more broadly also to put that in the context of the Sustainable Development Goals, and then maybe end on a note of hope. And so that's my rough roadmap over the next 20 minutes or so. And, to start, I would say on the lessons, there's really three lessons from the pandemic, and those are equity, equity, and equity. I think it's really uncovered the importance of equity, both within countries, and we see examples in Canadian cities, in Montreal, in Toronto, of communities that have been left behind, and sometimes great examples of community leadership. For example, the Black community in Toronto advocating for disaggregated data, showing inequities, and then using that data really to begin to remedy those inequities. So within countries on a wide range of social and economic variables, but also between countries, of course, the inequities. And I'm going to zero in on the lens of vaccine equity, but it's really just an illustrative example of the top lessons on equity, equity, equity. And also just to say that going forward, we have to be alert, because now we're hearing from some quarters the pandemic is over. It's not over. To channel Lenny Kravitz, it ain't over till it's over. And we're hearing a lot about endemicity. And some of that may be true, but we have to be very careful that it's not used as an excuse to perpetuate inequities. The hope that I'm going to end with, I know there's a lot of young people and young researchers here in the audience, and that's really the hope. The hope is science. The hope is young people solving problems, and that's where I'm going to go towards the end. Also, maybe I'll just emphasize up front that some of the related issues that we've learned about related to equity have to do with community leadership in general at all levels. And in a sense, leadership, even though I'm going to talk about vaccine equity, in a sense, leadership is the ultimate vaccine against COVID and the other global challenges that we face. And a byproduct of leadership, of course, is trust. And surprisingly, that's a variable that's been shown to correlate strongly with pandemic outcomes and pandemic preparedness. Maybe not surprisingly, but even more so than some of the capacities that we measured. So that's all by way of introduction. And now what I want to do is to turn to some of the failures of the pandemic, because we start, I think, with the problems and then go to the solutions. To me, the most fundamental failure has been a failure in our own human values. There are, modeling shows that around 1 million lives could be saved simply through the distributional effects of vaccines. Right now we have a great situation of inequity. The fully vaccinated rate, which is 2+ doses, is above 80% in Canada. It's about 15% across the African continent. And so there is huge amounts of inequity. And so there's modeling done by Greg Gonzalez at Yale that shows that maybe around 1 million lives could be saved by righting that inequity. But I'm sure that there are more than, I'm not sure, but presumably more than 1 million lives have been lost simply as a result of the distributional effects. So the vaccine inequity we're talking about is translatable into millions of lives. And the most fundamental failure is a failure of ethics. To allow that type of inequity to persist around the world, you really have to ask yourself whether we truly believe that we are our brother or sister's keeper, and whether we really do love our neighbor like we love ourselves. And so fundamentally, there's a huge ethical failure on which those numbers sit. A failure of equity, a failure of solidarity, and a failure of empathy. I think the issue here is if you see people as the other, as opposed to someone like you, that is the root of many of the global challenges we face. And it's the precondition for being able to tolerate that amount of death and that amount of inequity, which is fundamentally just intolerable. Now, on the basis of this, sitting on this foundation of an ethical failure, there's, of course, an economic failure. The pandemic has cost, according to the IMF, will have cost 13.8 trillion is the current estimate through 2024, which is an enormous amount of money and much larger than the amounts of money that seem so difficult, unfortunately, to mobilize for vaccinating the world or for fully responding to the pandemic. There's also a terrific epidemiological failure, a failure to understand. Of course, the primary goal of vaccination is to save lives, and it's very effective, even with Omicron, at saving lives, at preventing death and severe illness. But it's also vaccination can also tamp down transmission alongside other measures like masks and so on, tamp down transmission. And the more the virus transmits, the more it mutates, the more the chance of variants. So there's not only a charitable aspect, if you will, to vaccine equity, there's also a self-interest, which is to decrease the likelihood of future variants, which will arise anywhere in the world and come back and bite us. And so one of the best ways to keep Canadians or keep people in any country safe is actually to vaccinate the world. And then finally, there's a social failure, because these, the virus, the ongoing pandemic, is fanning the flames of social unrest. And we see that in Canada, and we see that around the world. So the story of vaccine equity, and maybe it's emblematic of the inequities generally, and I started by talking about some of the more general inequities. The story of vaccine equity is a story which has a foundation in an ethical failure, and then layering of economic failure, epidemiological failure, social failure. It's overall a very, very sad story that fundamentally goes to questions of human values and questions of whether we actually truly believe that all lives around the world are created equal, because in some ways we're not acting like we believe that. Now, moving from the failures to the solutions, specifically for vaccine equity, I want to say up front that WHO's target is that every country vaccinates 70% of its population by July of this year, by July of 2022. And at the moment, 21 countries have vaccinated less than 10% of their population, which means the most vulnerable people are unvaccinated. And this is the denominator here, by the way, is 194 member states of WHO. So out of those 194 member states, 21 countries have vaccinated less than 10% of their population, and 70 countries have vaccinated less than 40% of their population. So there is an incredibly long way to go in an incredibly short time on that 70% target. And it's when you're faced with a challenge like that I think it's important to remember the very wise words of Nelson Mandela, which is that it always seems impossible until it's done. But vaccinating the world, as I mentioned, could save around 1 million lives now. That's what the modeling shows going forward. And the cost up to this point has probably been at least that. Now, in thinking about this, and this is also where I want to acknowledge the letter of Professor Dasgupta and the 228 of you who participated in that. So you're certainly not idle on this topic, and I fully understand that I'm speaking with folks who not only understand this topic but have been very active on this topic, which of course is greatly appreciated. In thinking about the solution set here, I like to think about the 3 Ds: dollars, doses, and domestic manufacturing. And let me go through each of those in a little bit of detail. In terms of dollars, I think it's fair to say that the world as a whole has not fully stepped up to the task of vaccinating the world. For example, there's always budgetary shortfalls in the Access to COVID Tools Accelerator. And even going forward, we see that the few billion or tens of billions of dollars to essentially mitigate the tens of trillions of dollars of damage, the few billions or tens of billions are not being spent. Having said that, on the dollars front, I think it's fair to acknowledge that Canada is one of the top contributors to ACT-A, to COVAX. It's one of the few countries that actually has paid its fair burden into ACT-A and COVAX. And hopefully that same generosity in regard to ACT-A and COVAX on the part of Canada will play out onto some of the deeper issues that we'll talk about in a moment, like, for example, primary health care. So, as the story is shifting a little bit, as there are more vaccines, the actual doses coming online, and it's clear that they're bumping up against distribution challenges in countries. the role of primary healthcare becomes more and more important. And by the way, that's not only a thing for low and lower middle income countries. There's distribution challenges in every country in the world. That's why the army was active in this area in Quebec, for example. And so it's very important that when we talk about those distribution challenges, we also don't other those health systems. These distribution challenges are everywhere, but they will require support, and they will require strengthening of primary healthcare systems to overcome. And of course, primary healthcare is very closely related to the idea of equity. And it's not just essential services, it's essential public health services as well, multi-sectoral engagement, and the engagement of communities. And then sticking with dollars, you've got WHO, and I hope we can talk more about WHO in the discussion period, at the center of the multilateral system, really funded about the level of a large community health center. It's probably got as much funding as a large academic health center in Montreal or McGill. And most of that funding is somewhat earmarked. So less than 20% of WHO's funding is flexible, which basically means you can't be nimble and you can't move the dollars to where the need is. And so when we're talking about dollars, starting with the acknowledgement of the funding to COVAX and ACT-A, thinking about the importance of supporting primary healthcare, and then thinking about the importance of actually supporting WHO to be able to do its job. The second D is doses. And here, more than 11 billion doses have been distributed around the world, but very inequitably. We've talked about that. Canada has contributed about 15 million doses to COVAX dose donations at last count, and I know this was part of your letter. It's also worth looking at the companies themselves and the extent to which their doses, for example, the RNA vaccines, went to low and lower middle income countries versus upper middle income countries and high income countries. And you certainly see for some of those RNA vaccine companies a very skewed distribution. And so the doses is a second issue. But as I said, the emphasis now is becoming balanced between supply and distribution. So it's a more nuanced picture. What I would like to emphasize is that the consistency of supply is also critical. So, if you're delivering a bottle of milk to me every day, and every day you're sending me a bottle of milk, and then one day you send me 20 bottles of milk expiring at midnight, I won't be able to use them either. And it'll take me quite a while to be able to distribute them accurately in the case of vaccines. So dollars, doses, but just to highlight that these are short-term issues, and the sustainable solution to vaccine equity is domestic manufacturing or local production. And it's very important that we've seen some moves here. I know that the letter that you all sent referenced the TRIPS agreement, which is important. And we have, in this case, the Director General of WHO, my colleague and friend, Dr. Tedros, supporting the original proposal of India and South Africa on vaccines and other tools to be exempt from TRIPS. But you also have something very, very important in the WHO technology transfer hubs, starting with the mRNA technology transfer hub in South Africa, which Canada is supporting, and moving more generally to the network of technology transfer hubs now. This is based on a successful model of influenza vaccine technology transfer that happened between 2006 and 2016. And of course, to have successful technology transfer, you need cooperation. And it's a matter of public record that the mRNA vaccine companies have not collaborated with the WHO hub. But this is very important because essentially it's a way to help countries to make their own vaccines. And there's been some early success in that mRNA technology transfer hub. And coupled with that, you've got another mechanism called CTAP, the COVID Technology Access Pool, which is about voluntary licensing and other things. And that's a very important piece of the puzzle. And then you've got the TRIPS agreement. So you've got a spectrum of things focused on local production. And this is in part about the intellectual property. It's in part about the technology transfer, but it's also very much about the know-how and teaching people how to do these processes. And, here's a good point. Here's a good moment to recognize some of the Canadian scientific contributions. For example, Peter Cullis at UBC and the development of the lipid nanoparticle, which is one of the key elements of the mRNA vaccine that was recognized, I think, yesterday in his Gardner Award with Kathleen Carrico and Drew Weissman. And so there's very strong Canadian innovation, science and technology. And that's a potential role for Canada, actually, in terms of technology transfer and helping countries really to become much more sustainable. Because as soon as there's a new variant for which there might be a new vaccine, or if there's a new, the next pandemic, and there will be a next pandemic, we will see the same vaccine inequity 2.0, and the thing will shift back to the supply side. Because what we've learned is that these global supply chains are not really up to snuff in the startup phase of a vaccine rollout. And so the local production, the domestic production is really important. So on solutions to vaccine equity, I think about it as the 3Ds. Now I'd like to shift from vaccines more broadly to the SDGs. Before I do, I think it's really important to say that even the tools part of this is not just about vaccines. Diagnostics is critical. Diagnostics are critical. Drugs are critical. And we see the importance of, for example, Paxlovid for vulnerable patients. Oxygen is critical. So even oxygen facilities. So the tools is even a much broader thing. And of course, the Access to COVID Tools Accelerator has distributed not only more than 1 billion vaccines, and by the way, a key role of WHO here has been the emergency use listing of those vaccines, 12 of them in 2021, but also the distribution of more than 100 million diagnostics, the oxygen plants, the steroids, et cetera. So now shifting to SDGs, this is where there's been real disruption in health systems and a real setback on the SDGs related to the pandemic. When we first started at WHO, and Nikki referred to this, we took the 50 health-related SDG indicators, because there's about 50 health-related ones. About 2/3 are within SDG 3, 1/3 are outside SDG 3. This is about out of about 170 something indicators. And we put them into 3 understandable, coherent ideas. And we set those as our triple billion targets. So what we said was between 2019 and 2023, WHO was going to support countries so that 1 billion more people would benefit from universal health coverage, 1 billion more people would lead healthier lives. Think about water and sanitation and climate and other things outside of SDG 3 that affect health. And 1 billion smoking, health promotion, and 1 billion more people are going to be better protected from health emergencies. So those were the targets we set. And by the way, that was the first time WHO set measurable targets across all the activities of the organization. Yeah, the SDGs are the Sustainable Development Goals. So the commitments that countries themselves made in 2015 for their attainment by 2030. And not only did we set measurable targets, but we also measured them. So I can tell you now, for example, that on all 3 of those billions, the progress is probably less than 1/3 of what we need to reach the 2030 goals. So on universal health coverage, the billion people that needed to gain access to universal health coverage, which of course is access to health services without financial hardship. Of those billion, before COVID, the shortfall was 720 million, not the attainment, the shortfall. And after COVID, the shortfall is 840 million. And so, you've got less than 20% attainment there. And you've got a similar picture, even though the billion goal was almost reached for healthier populations, it turns out the target's closer to 3 billion. And so again, about 1/3 attainment. And on health emergencies, you have an even bigger surprise, because the things that we thought predicted preparedness, according to a study and some work published about a month ago by the Institute for Health Metrics and Evaluation and the Council on Foreign Relations, health systems doesn't really predict pandemic preparedness, health system strength. The Global Health Security Index, things like that, which have to do with international health regulations capacities, don't really predict pandemic outcomes, either infections or deaths. The thing that predicts pandemic outcomes, super interesting, is trust. Trust in government, trust in each other. And that's why I emphasize the importance of leadership. So at a minimum, this is a much more dynamic system. We anticipated a little bit this in the emergencies billion because we had time to detect and respond as one of the sub-indices. And of course, that's a dynamic thing, but it means we have to shift our attention much more to intra-action reviews, simulation exercises, that dynamic decision-making, and at the end of the day, the importance of leadership. So bottom line on the SDGs is a huge job to recover, not only related to vaccine equity, but more generally. Primary healthcare can help us here. And of course, it's important to recover in an equitable fashion, because leaving no one behind is at the essence of the Sustainable Development Goals. So let me now turn towards my conclusions. I started by saying that the lessons of COVID were equity, equity, equity. I sketched that that's a broad sweep of situations within countries, between countries, but I zeroed down on a vaccine inequity between countries. I talked about the failures of the pandemic and the failures of vaccine equity, the foundation of ethical failure, which I think is the most fundamental of all, and heaping on top of that the economic, the epidemiological, the social failures. Then turn to solutions in the 3Ds. And as you go along, doses, dollars, doses, and domestic production, manufacturing, it gets more and more sustainable. And I went into some detail on domestic production and the type of technology transfer arrangements that are needed. And then I zoomed out and talked about the SDGs generally, which are way behind as a result of vaccine inequity, as a result of COVID, but actually even very much predating COVID, and talked about some of the measures that are needed to accelerate SDG progress. Actually, that I didn't talk about much, but they are things like scaling innovation, better collaboration in the multilateral system, innovative finance, and just being really precise about delivery. What indicators are behind, tracking them at the country level, intervening on them, focusing on them, et cetera. And now in the conclusions, I want to end with hope. This isn't a council of despair. There's also been a lot of positive examples in the pandemic. Triumph of scientific discovery, even if we had a bit of a failure of humanity a failure of humanity in the distribution and the inequity. Great examples of community leadership. For example, you've seen terrific leadership on vaccination in Canada's Indigenous communities. And by the way, as an aside, I know there's a lot of discussion, which is very important discussion, about decolonizing global health. The ways of knowing of Indigenous communities are hugely helpful and hugely informative on the issue of decolonizing global health. And that's a comparative advantage of Canada, by the way, which we initially referenced 10 years ago in the Canadian Academy of Health Sciences report on Canada's strategic role in global health. A lot of positive examples, but to me, one of the most positive things is the work of young people. And for example, the work of scientists in Canada, the work of young people, the work of people in the audience here. You know, I know about some of Nikki's work, some of Madhu's work, and the work that you are all doing to address this. And so I want to end just with that hope. We have great examples like Vaccine Hunters Canada, for example, which matched a group of young people. They found a problem matching people to vaccine availability. They addressed it. And so my top advice to young people is find a problem and solve it. And by finding a problem and solving it, which is what each and every one of you is doing in your work, there's great hope in that, particularly as young people find a problem and solve it. So I'd be remiss if I didn't just say at the end of this, it's looking like we're on the upswing in Canada. And so we have to maintain our guard. We have to maintain our guard, I would say, on the A, B, C, D, and E's. The A there being aerosol, airborne. WHO has said the transmission of COVID is through droplet spread in close quarters, mostly transmitted at a conversational distance, and also through aerosol airborne spread at close quarters and further away. And so that leads us to very important public health measures like masking, opening windows, ventilation, filtration. The B standing for boosters. And as Tedros said early in the Omicron wave, WHO is not against boosters, we're against inequity. But it's very important on boosters to follow the local public health guidance, the C for crowds, to avoid them or to limit gatherings as you see this upswing. The D for diagnostics and drugs, just to remind us that there's a suite of tools there that are really critical. And the E, maybe the most important of all, for equity. And that's actually where I began, and that's where I think I'll end. I want to really thank you for your attention. It's been great to be able to have this opportunity and look forward to maybe about 25 minutes to be able to interact with you and to have a conversation and address your questions and comments. And most of all, thank you. Thank you for everything that you're doing to combat the pandemic, to combat inequity, and to improve global health and health in Canada. So Nikki and Kaberi, back to you. And thank you so much for the opportunity, and really look forward to the back and forth.
That was a great overview, Dr. Singha. The floor is open for questions. I have one question. Could you mention something about queue shifting? Like, do you think it's a good strategy? You know, like US is trying to defer its doses and trying to give it to the African Union. So can that be done? Because, you know, we've had boosters here. We are talking about boosters and people haven't even had, in Eastern Africa, the vaccine coverage is less than 5%. So can that happen? And then in South Africa, I was talking to my colleagues and they said, it's not about production or supply. So certainly it's about supply chain, but there's also a lot of vaccine hesitancy in the population. So I don't know how soon can they ramp up all of these educational and awareness programs so that people come forward and get the vaccines. So those are the two things.
Yeah,
to
great.
Just start off.
Sure. So just on that, I think it's important to take a balanced approach to the supply side and the demand and distribution side on vaccines. And on the demand and distribution side, it's the things in primary healthcare, it's the logistics, it's the delivery, it's the person power, et cetera. But it's also the consumer demand or the patient demand and that's where vaccine hesitancy comes in. There's been what my colleagues have called an infodemic, a lot of misinformation that does sometimes lead to vaccine hesitancy. But what I want to emphasize is vaccine hesitancy is not just an issue of information. Most fundamentally, it's an issue of trust. And if you belong, and it ties very much to inequity, because if you belong to a community that has suffered for the last 100 years from unequal treatment and from inequity, and in some cases from racism and from violence, you will not be so trusting of people coming at you with vaccines. And so, for example, there's a long history of exploitation of African American communities in medical research, and so there's a distrust there that has been built up over time, and that's why community leadership is so important. So, to me, vaccine hesitancy is more fundamentally about trust than it is about information, and it's about community leadership. And the reason I mentioned the African American example is vaccine hesitancy happens everywhere in the world, and it's not an excuse to diminish supply. Neither is distribution. And that's often how it's used. And that's why I focused on the othering. So yes, it's an issue everywhere around the world. And yes, it needs to be tackled along with the other distribution issues. And most fundamentally, it goes to trust. And if anything, it's a reason to increase supply and not decrease supply to overcome some of the roots of that distrust. Now, on the Q shifting, we're now in a situation where it's much more nuanced between the supply and the demand. So a lot of that inequity during the ramp up, starting at the beginning of 2021, we are about, more than 15, 16 months into a vaccine rollout now. A lot of the initial lives are lost early on. And there was what was called vaccine nationalism early on. There was a lot of ordering happening, which of course was more on the order books than on but still that Q shifting is a mechanism in a situation of scarcity to ensure that the supply is evenly distributed. I mean, what really blows my mind is that we're talking about probably millions of lives here, at least hundreds of thousands, that are not dying as a result of what I'm saying is with the same amount of vaccine distributed differently, there's the potential to save millions of lives. And of course, that's very difficult to do politically, but it's essential to do to a very large measure humanistically. And that's why, one of the things I feel proudest about in working at WHO, and I think one of the biggest contributions of WHO in the last year or so, has been the leadership of my brother, Dr. Tedros, who every time he talks emphasizes the equity issues, the global equity issues, and the importance of not only vaccine equity, but equity more generally. And he's really been an unrelenting advocate for that in more than 250 news conferences, weekly meetings with all the governments in the world, and in many, many other fora. And so that makes me feel very, very proud. And that's what's at the fundamental heart of your question about Q shifting. It's about whether we really truly value all lives equally. That's fundamentally what it's about. Q shifting is a tactic or a mechanism to show that we do.
Over to you, Kaveri.
Yeah, there's some wonderful questions, so I want those to have a chance, but I just wanted to touch on the topic of trust, because so first, as a researcher, I was going to say, what measure of trust are you using? But the second is, I'm not sure that trust is probably, you earn trust, right? And I'm not sure that it's simply kind of a health promotion addressing vaccine hesitancy issue, as much as it is countries or jurisdictions that have helped people as they fall off an economic cliff, whether it's in Canada or New Zealand, and provided supports to people that were losing their jobs and losing their childcare. They've earned trust. And so then you get the 80% plus vaccine rate. So I think it's, maybe one has to be cautious in using the word trust. I think it really, and it isn't simply historical inequities, but current inequities that are not addressed. So I was wondering if you could comment on that and on the measure of trust that you were referring to.
Yeah, no, I fully agree. And let's start with the easier issue, which is measurement. So there is that Lancet paper from about a month ago or 6 weeks ago from one of the authors was Tom Boyke from the Council on Foreign Relations, and they did it in concert with IHME, and you can look up the exact measure there, but I think it's called the World Values Survey. So there's this World Values Survey that's actually measured trust in government, trust in each other. And of course, it's self-responded survey type data, but done it consistently over many years. And that is a data source. There's another data source they mentioned there. And then on the other side, you've got the Edelman Trust Barometer, which is a lot of deeper questions about trust and trust in government and trust in WHO and et cetera, but in a limited number of countries, I think around 30 countries. So those are the two data sources that I'm aware of. Now, just to your other points, I just fully agree with what you had to say. Trust is earned. I think it's a byproduct of leadership. But the model there is much more complicated than that. I just want to fully agree that it's not just how you do on an individual thing like vaccines. It's a broader sweep. And of course, that depends who you are. It depends on the social and economic supports, for example, that you offer most vulnerable citizens, in particular communities. So I think one of the points implicit, one of the things you mentioned was that it's across a series of measures. I agree with that. It's repetitive over time. It's earned. All those things are true. Of course, when you're thinking about measuring pandemic preparedness, it becomes quite a difficult variable because in a sense, it's the last thing. And it might be explanatory, but the extent to which it's actionable, I think, is the question. I think that the traditional measures, which are like IHR capacity, which, by the way, did not correlate with infection rate. I think those things are still very necessary. I think what the study shows is they may not be sufficient and that a more dynamic look is needed. And that's why I pointed to the after-action reviews. I think probably also multi-method measures are needed because when you're looking at these complex phenomena like trust, you can't completely quantitate them. And I cited two quantitative data sources, but to be actionable, you also need the qualitative case studies and the multi-method measures. So as we're thinking about how to measure, our current health emergencies billion measure has three sub-indices. One is called PREPARE, which is basically the IHR SPAR indicators. So it's 14 or 16 capacities. Like, do you have a diagnostics lab and stuff like that? We've got PREVENT, which at the moment is vaccination for yellow fever, for example. It's a measure of vaccination capacity. But I think another key thing there is IPC and health worker infections in terms of PREVENT as a way of thinking about the measurement construct. And then we did put in DETECT and RESPOND, which is the time from when WHO is notified to when there's an actual response at the national level, for example, to a particular signal. And we put those three indices together. And what we now know is we probably need to pay a little bit more attention to the dynamic side of that measure, the detect and respond, maybe break it down syndromically. So there's a lot of active work. And we need to consider the trust piece, but that's over there and we're over here, and we need to evolve the measure, and we need to be more ambitious, because if the pandemic taught us anything, it's that no country was prepared. And our 1 billion target for health emergency, it should probably be the world population, which is 8-point-something billion, I think, in 2025. But it can't be everybody's fully prepared, because that's unrealistic. It has to be progressive realization. So we also stratify countries into 5 levels of preparedness based on that index. And, one idea would be to say that the entire world population, namely every country, should move up at least 1 level over a 5-year period, and some kind of progressive realization. So, there's just some thoughts about the measurement. I know this is a measurement crowd and an epi crowd, so I'm delving into some thoughts, but this is very much in play. What I can say, maybe just to close off this discussion, is it's been incredibly useful to focus on measurable targets across the whole organization, and then to work backwards to the data sources, because countries care a lot more about data than they care about indicators. And so there's this thing called SCORE, which is essentially an X-ray of data systems and data system deficiencies, and then to work forward from there on what you actually do with the data and how to translate it into decisions, something I know my friend Charles Larson has focused on for a very long time. And that's delivery. So with a few indicators, when they get off track, what do you do about it? And so that whole data dynamic has very much driven WHO over the last 5 years. We've really only laid the foundations, but that can be a very powerful thing to roll out at the heart of the multilateral system and to build on further. This focus on results, this focus on measurable impact, those are the two words at the heart of our strategy. And as I'm illustrating, some of the deeper technical issues in one of those measures, I want to just also zoom out and talk about the importance of measurable impact to the strategy as a whole.
So Luis, talking about those measures and data, Luis has a question about, can you update us on WHO's policy on COVIDence, because sex disaggregated data was lacking, and so inequity predominantly impacts women. And so in LMIC's vaccination policies paying close attention to access to women, access of vaccines to women. So could you just talk about that? And then there is Megan, I think she's young, and she's saying, you emphasize the importance of young people. While I agree that young people have a lot to offer, I'm concerned older people in positions of power are pushing the responsibility for solving these problems onto younger generations. So do you think there is a political will among those who are already in policy making positions to make impactful changes on these issues? And Charles has a question on, it appears to me what has trumped all well-meaning efforts to respond to this pandemic is the politics of global health and the dominance of national interests. Could you comment on how this has affected WHO to play a much-needed leadership role?
Sure. So on the gender equality, and thank you, Louise, and good to reconnect. So gender equality is at the heart of what WHO does. It's gender equity and rights is at the heart of the strategy. But it's necessary but not sufficient to have something in strategy. I think the innovative move that we did was to actually measure it. So we brought in a balanced scorecard approach into WHO. So every unit, if you will, every department, every activity rates itself on gender equity and rights, and then uses that as the baseline for improvement. So, there's problems with the measurement, of course, it's self-reported, et cetera. But it's one thing to talk about it, it's another thing to measure it. And what I'm saying is that's what we're doing internally within WHO, on top of many other DEI type of initiatives. In terms of the specific question on vaccines, it's a very important question. Nikki called out the SDG 3 Global Action Plan about how the multilaterals are working together. One of the contributions of UN Women, and actually an equity cluster with UNDP and also working with WHO, has been a gender equity checklist that can be applied to vaccination. So really, just to say, it's an incredibly important question. It's in the original strategy before COVID. It's not enough to have it in a strategy, you also have to measure it. And it's also something that is very much part of the vaccination effort as well, and in terms of measurement as well. In terms of the young people question, that point about young people are hope, et cetera, it's got to be more than a slogan and a way to pass the buck from older people to younger people. If I could put words in your mouth, I think that's what you were saying. I mean, what's needed here is leadership across the board. And that's why I said at the outset, leadership is the ultimate vaccine. It's the most effective vaccine against the pandemic, but also against the conjoint global challenges that we face. If you can't have leadership in the middle of the worst pandemic in 100 years, you're not going to get leadership on climate. You're not going to get leadership on racism. You're not going to get leadership on economic inequality. So just to say, in a sense, it's the final common denominator on these conjoint global challenges. Now, when I say young people, hope, etc., it's not an either or. We need the best leadership out of leaders in all levels of the system, whether you're a head of government, whether you're a community organizer and leader, or whether you're in an international organization. And I referenced the leadership of Dr. Tedros. But I also think that there's an incredible amount of hope and opportunity in the leadership of young people. And yes, that does require a little bit of leaning out as well. So to use a personal example, one of the things I'm really particularly proud of is actually having left Grand Challenges Canada in the CEO role, and the succession there of two young, they're certainly a lot younger than me, younger women who adopted a feminist co-CEO model of the leadership of Grand Challenges Canada. And that's one tiny little example of leaning out. So I do think there's a need to for others to lean out as young people lean in, but not only young people. This is a very important point in diversity, equity, and inclusion. You know, the leadership at all levels has to be representative of the people that are served. And so, you know, another thing I'm quite proud of is when you look around the room now in terms of, for example, the executive management team at WHO, it's quite diverse, not only in terms of gender, but also in terms of national origin. When you're looking at the layer of directors, which is kind of one management level down from there, you're also starting to see quite a bit of that diversity. So, so there's a need to lean out as well as a need to lean in. And as young people are leaning in, people need to, encourage, help, and mentor. And we don't have the time now, but I've got a little video on my YouTube channel which talks about advice to young people, which is some of the things I'm picking up. It's on my LinkedIn page. And I talk about leaning out. I talk about some of these other things. And I think it's just a terrific challenge that that was asked in this question. And to Charles, maybe I'll just personalize it again. And Charles knows this because we were together before I went to WHO. I used to think about the multilateral system as very inefficient and messy and couldn't get stuff done. And, part of that was the governance model of 194 member states. I now realize what an incredible comparative advantage that is for WHO. It is that idea of inclusive governance, and it's very relevant to pandemics because they can start or end anywhere. Inclusive governance might be a little less efficient, might be a little more messy than just doing something if you're a big foundation or if you're a strong government and you're a G1 or a G7 or a G20. WHO in a sense is the G194 for health. And there's a real value in that inclusive governance, especially, and it connects very much to the points we were talking about equity, and particularly seeing people as your brother and sister, and regardless of where they're from. And so I actually see that governance model as critical and a bit of an antidote to the othering that we see that leads to some of the inequities that we see. The other comparative advantage of WHO, by the way, is the 152 country offices and the social capital and trust between those country offices and the governments. So you asked a question about politics, and I answered it with an answer about governance. There's no question that the geostrategic issues play out, and you don't need me to tell you about that. WHO is it's a very strong diplomatic entity. For example, if you look at Tedros' Twitter feed today, he's in DC meeting with top congressmen, top senators, National Security Council, Treasury Secretary, etc. There's a very strong diplomatic effort in relationship to WHO, and I think that's very appropriate because political will drives technical change. So I think diplomacy is a strong suit of Tedros, certainly, and of WHO. I think the inclusive governance is really important. And And maybe those are the best terms that I can use to respond to your question about politics, while acknowledging that obviously no international organization is immune from the broader political currents that affect the world today. But I think the action pieces are in the governance, are in the leadership, are in the diplomacy in terms of making the world a better place.
A brilliant young colleague has. It's about McGill and the partnership with Moderna. They announced a partnership recently, and Faiz is asking, what role should our university play in pushing these companies to share the technology in pursuit of vaccine equity? I think we've talked about that for a long time in our letters also.
Yeah, I think it's a really great question. And the answer is any role you can. I mean, you know, when you look at Moderna or Pfizer, it's a matter of public record that a certain proportion of their vaccines, and not a big proportion of their vaccines, went to low and lower middle income countries as opposed to upper middle income countries and higher income countries. And by the way, I think the best reporting on this is an Amnesty International report on vaccine equity, where there's actually a table, company by company, and the proportion of their vaccine production that went into. None of the companies have participated in the technology transfer hub. And none of them have participated in the COVID technology access pool in relationship to vaccines. Some have in relationship to drugs and to diagnostics. And so I think the role to play is any role you can, but it's an astute question, because if governments don't, for example, invoke measures that require companies to do something, for example, in the US, the Defense Production Act, and if the management and the board of a company don't act in the way that you might want in terms of equity, then you're left with a broader public response. And just to focus that a little bit, what you might do is think very hard about the investors in a company. So I have a piece that was in Barron's online, and I'll retweet it, but essentially it argued that shareholder activism is a reasonable approach here on equity as kind of a last line of defense that needs to be tested a little bit. This is based on experience in climate. There's a particular thing in Exxon engine number one, if you know that case. But just to point out that the annual general meetings of these companies are coming up in the spring. They're always in the spring. The investors meet there. There are shareholder resolutions that are relevant. So for example, Oxfam has introduced a resolution at the Moderna and Pfizer and other company annual general meetings around sharing technology. They call upon the company to study, I don't have the words exactly right, the feasibility of sharing. It's a very light resolution. It's like, study the feasibility of sharing technology. Well, shareholders will have voted on that resolution. So there's a very concrete, actionable piece there that can be the focus of your efforts. There are good reasons why investors would want to the company in which they invest to share technology. I mean, for one thing, if you're a universal owner like a BlackRock, which is one of the top owners in these companies, you're influenced very much. You own shares in every company in the market. And if the market goes down as a result of the variant, you'll lose much more than you'll gain in an individual company. If you're an active investor like Baillie Gifford, which owns about 10% of Moderna, you know, the perceptions really matter, and you need a license to operate. And so you want to be associated with some of those ethical, so-called ESG positive outcomes. And certainly if you're an ethical investor, you know, which would be smaller investors like Church of England or something, you have to live your values. So one thing you can do at McGill is, you know, we're all part of pension funds and stuff. Are your pension funds investing in these companies? What are they saying to these companies? I'm just going on the investor side as something to consider, and of course that is in addition to your partnership with Moderna that you referenced. So I just use that to show a potentially innovative ESG market shaping approach that you can take part in, because people have investments, people have pensions, not everybody, because it's the other side of the equity issues, right? A lot of people, but you can use institutions like, for example, the McGill Pension Fund, and ask about those investments, and ask what questions they've asked those companies on things like vaccine equity. It's just a very practical suggestion in response to your question.
There is another last question, and then I'll pass it on to Kaveri. It's from Lena. She says, apart from writing letters, what can we actually do? Because most of the decisions are taken by leaders. And so what hope do we have for achieving vaccine equity, other than, apart from advocating, writing letters, which is valuable, but evidently not sufficient? So she's a little...
Yeah, I would just say, don't underestimate the importance of activism. It's the only thing that's ever actually changed the world. In a headline, equity is in your hands. It's not only something that's done to you. It's in your hands, which is why the activism that you showed and the public interest in that letter is so important. In fact, that kind of organizing at the community level is extremely, extremely vital. There's some good work by a colleague, Ben Phillips, who has studied global inequalities and has really highlighted the importance of community organization, community activism in addressing inequalities. And he makes the point that it's the only thing that ever has. And so the first thing to do is not to underestimate the importance of what you're doing. What else can you do? I would always think that if you are a scientist, and I know a lot of the people on this seminar, this is the Research and Student Center at McGill, I think it's always best to leverage your own capabilities. So the other thing you can do is the research that sheds to light the inequities, the disaggregated data work. There's a lot of work on equity that can be very, very evidence-based. And so that's another thing that you can do that is probably more important than anything else, because it's leveraging your strengths. And then finally, I highlighted a very concrete set of actions just a moment ago regarding investment, regarding capital, and something else you could do. So whatever you do, just keep doing what you're doing, and keep, this is where hope lies. And it's also why I quoted Nelson Mandela. It always seems impossible until it's done. And don't underestimate the importance of community voices. And it may seem like it's not working in the short term, but in the long term, it works. And at the end of the day, governments have to listen to their citizens. Companies have to listen to their investors. And the more evidence you have behind that case that you're making, the stronger the case is. So at this point, I would just say, have confidence in what you're doing, and don't underestimate its value. I just want to show my respect and appreciation for the work that you're doing, and for the steps that you've taken, and for the advocacy that you're showing.
So are you saying we should write more letters, Dr. Singer, and they get read by your offices?
They do, and letters do help. And there was a question, I think I saw it come by in the chat, related to national interests and national political. The first role of a government is to protect their citizens. So everybody fully understands that. But government's freedom to operate flows from the support that they have from their citizens. And so, when you write a letter, it's not just writing a letter, it's providing essentially a license to government to do things that are politically hard. It's not politically easy to share vaccines, because the first role of government is to protect your citizens. And so it'll never be politically easy, but you are providing space that enables that when it comes to governments, because at the end of the day, governments follow the will of their peoples, and especially domestically, because those are the people that vote in that particular country. And companies follow the will of their investors, especially their biggest investors, which is why I was talking about the biggest investors. And the gap, by the way, on the shareholder activism is you've got groups with, say, 3.5 trillion under assets under management that are working, but not the very top investors. And some of those I mentioned. And then I think the most proximate thing is the evidence that you're generating. Evidence does matter at the end of the day, including evidence about inequities. And there's a great case study by Kwame McKenzie about what I mentioned, the Black community in Toronto, the disaggregated story, the disaggregated data story. I mean, that is essentially a story about equity and data and disaggregated data and evidence and community activism all rolled into one to help to work towards decreasing the inequities. So also don't underestimate the importance of data and the importance of evidence, which is probably the thing closest at hand to your interest, not to mention clinical trials, biomedical science. I referenced the lipid nanoparticles. I mean, all that stuff really matters. And on the equity issues, the evidence I think matters a lot, and the data really does drive change. It's not sufficient, but it's necessary.
Over to you, Kaberi.
Thank you so much, Dr. Singer, for taking the time to spend over an hour with us. And, to I was delighted to hear you're an internist like some of us, myself included. And indeed, we have, well over 100 research grants at our research center addressing COVID and its relationship and interactions with other diseases. I recently got a grant from the CIHR looking at diabetes and inequities and how if they've increased during the pandemic. So we'll be very happy to share our findings with you, and we'll keep writing letters, and we're counting on you to at the higher level rally governments to address some of the issues you were talking about and show the leadership that we need. Because I guess as a last word or as a last question, I'm wondering what you think the next year or 2 or 5 hold, because really it sounds like the path to inequity and achieving those vaccination goals is not going to be by July, as far as I can tell from the numbers you quoted. In which case, I think we're just going to keep riding various waves, and that's depressing to all of us, and much more than depressing to many. So if you have some comments on that.
Yeah, I mean, the first comment is, again, to show my respect and appreciation. You just gave another great example that I didn't mention. The other thing that predicts pandemic outcomes is, at least in terms of mortality, is obesity, diabetes. And so it really shows how the distinction between communicable and non-communicable disease breaks down. And so it's just another great example of how your research work can really help guide the way forward for health policy. The second thing I wanted to say in response to the very kind comments you made, Kaberi, is, you think about WHO as this thing over there, this global thing over there. WHO is you. WHO is all of us. And that's really the way to think about it. It only works if it's seen as a platform, as an essential global platform for mobilization of all of us. So if there's any way I can help to connect your work to WHO more narrowly defined, I'd be glad to do that. But I want to make a broader point, which is really that WHO is you. So don't think about it as something distinct. Get involved, get engaged. I went there, as Charles knows, with a healthy dose of skepticism. Having led a collaborating center and having led Grand Challenge Canada in official relations with WHO. So I did have some relationship. But once I got there, I realized, messy though these things may, it's an essential institution, and the UN generally, WHO in particular, for safeguarding the interests of the most vulnerable people in the world. And vulnerable people are in every country, as you know. So I would say not only get engaged with WHO, but I would say you already are engaged with WHO and let's work to increase the engagement and contribution of Canadian scientists and researchers across the board in the work of WHO. And that's you. And if I can help, I'd be glad to do that. And then finally, your question was about prediction, and that's always dangerous. I think that's why I pointed to the moral failures at the heart of this, and that's where I would focus. What is it about the way we live that lets us tolerate millions of deaths? What is that? Do we really believe that all lives are created equal? Do we really love our neighbor like we love ourselves? To me, that area is the nugget of everything and the lesson going forward, because that's the essence of action in climate change. That's the essence of anti-racism actions. It's the essence of actions against inequalities. It's at the heart of everything. So I know you didn't ask a question at the level of values necessarily, Kaberi, but I think that's the lesson we need to very seriously reflect on and learn. More generally, the virus, as my colleague Mike Ryan says often, is not going away anytime soon. It is still with us. And that's why I played out that ABCDE story a little bit, because it's a question of what we do about it individually, but also as a government. And there is a risk, of course, of the cycle of panic and neglect. That is the history of pandemics, which is you're in the middle of a crisis, it's a panic, and then the crisis, you basically declare that it's moved on, even when it hasn't fully moved on, and you begin the neglect part of the cycle. And that's a real risk at this moment. So I think what is going to happen in the immediate future is what we're seeing, a new wave unfolding in Canada. The wastewater things are starting to peak. I think there's a decoupling, thankfully, between infections and deaths, largely due to vaccines. I think that decoupling is not the same everywhere in the world. So we're going to see many, many more deaths. And that's where we're at, that's where we're at for now. But maybe the place to end is that, quote unquote, endemic COVID, quote unquote, living with COVID. Let's just be sure that that doesn't mean leaving the most vulnerable people behind, because often it can be shorthand for that. So I think if anything, now is the time to redouble our efforts, not only on the public health measures, but also on the obvious concerns for equity that you've shown through the pandemic. So thank you very much for the great interaction. I've really appreciated connecting with people I knew before and people I've just met, and look forward to continuing the conversation. I'm at Peter A. Singer on Twitter and would love to stay in touch with you and help in any way that I can, because at the end of the day, I think Canada as a G7 and as a G20 country, with a strong stated interest in multilateralism, historically has a potentially a very strong role to play in global health going forward, and that means all of us working together to make that a reality. So, Kaberi, Nikki, and others, I just want to thank you for this time. It's been great to be with you, and I hope to talk again soon.
Thank you.
Thank you.